How do we bridge the gap between research evidence and real-world palliative care practice? What can a case study from Kenya teach us about pain management relevant to Colombia? How does end-of-life care differ in rural India and urban Brazil? I'm Jane Bates, and I want to invite you into a global conversation about palliative care. Welcome to Palliative Care Matters, where healthcare practice meets evidence-based learning. This podcast is for anyone interested in palliative care across the globe. In each episode, we will hear stories from practitioners like you, followed by discussions that connect and inspire you in your daily work. So whether you're in a busy hospital in Lagos, a community clinic in Bangladesh, or a care home in Manchester, you have stories that can teach us all something valuable about compassionate, evidence-based care. Feel free to submit your cases, send us questions, and join this global learning community. Palliative care matters, because palliative care isn't just a specialty, it's something we all do. Subscribe wherever you get your podcasts. I'm delighted to introduce to you my guests for today's podcast. We have with us two of the 6 author team of a really interesting paper which came out earlier this month in BMC Palliative Care, which is entitled Socioeconomic Profile and Vulnerabilities of People Receiving Home-Based Palliative Care in Kerala, India. And I was particularly drawn to this paper because I think it presents some really interesting and new data. So thanks to Parth Sharma, who's the corresponding author, I think, and Deepak Sudarakan, who is one of the author team. So if I can ask you both just to tell us a little bit about yourselves, and we'll get started.
Deepak, you want to go
After you,
first?
Path.
Okay,
No,
sure.
always you first.
Okay. So my name is Parth. I am a physician by training. I did my undergraduate from Christian Medical College, Vellore in Tamil Nadu, following which I worked in medical oncology for a year, then adult emergency, and currently I am finishing my MD in community medicine from Delhi. This work was done as a part of a not-for-profit organization called Association for Socially Applicable Research, which is a volunteer-run think and do tank that generates evidence which can shape socially relevant policies. So I lead the Cancer and Palliative Care Research Group, which collaborates with Palliative India, and that's how Deepak and I got in touch and did this paper. Over to you, Deepak.
So, hi there. My name is Deepak. I'm a community medicine doctor who got trained from Kasturba Medical College, Manipal, which is in Karnataka. And it's during this time that I got exposed to what is palliative medicine. And I realized that there is a care side to it, that is palliative care. And though this was not a core competency as part of the training of community medicine, it's not part of the curriculum. But later on, I realized that this is very well, what is required in the community, which is the principles of community medicine coming together to support people requiring, palliative care. And how can we bring these two principles together to serve those who are in need? That is how the whole journey started for me. Ever since then, I've been active in the space of public health palliative care, supporting in not just direct patient care, but also looking at strategies to see that this can be scaled up, and supporting organizations to better their palliative care services for those in need. Yeah.
Sounds like I need to have another chat with you about your work separately. You're obviously very passionate about it, which is really great to hear. I don't know if you, Parth, you wanted to mention any of the other authors. You talked about how you came together with Palliative India. Are all the other authors part of Palliative India, or a variety of folks from different groups?
So it's mainly authors from ASER, which is not-for-profit, and Palliative India. So this work was led by Jashan Jot, who is a third-year medical student from AIMS Bathinda in North India.
Right.
And the other authors are Shreyas Smriti from Palliative India again, and Dr. Sunil Kumar from Palliative India. So
Great.
this was the entire team along with
That's a good encouragement to all third-year medical students to get out there and get their work published. Hey, excellent. So Let me ask if one of you would kindly provide an overview of the paper. I've obviously had a read through it a few times and have got some questions that I want to just explore with you afterwards. But if one of you would be kind enough to provide an overview, and then we can get into some of the nitty-gritty. Would that be all right?
Yeah. So I can give a background on why we did it. So if you look at palliative care evidence from India, there is a lot of evidence when it comes from the clinical point of view, but not much when it comes from the public health point of view. And that's where Deepak and I started talking with what data which is already there at Palliative, which can be utilized to understand the public health side of palliative care. And this was the time when I was visiting Palliative India around 3 years ago. And we were going through files, and I noticed there was a lot of information in the files. Questions like, can you afford food? Can you afford medicine? Did any kid in your family drop out of education? And Deepak and I felt that these questions were extremely relevant to understand the people rather than the disease. The people who were suffering because of the disease, because it's most often the entire family that was suffering, and not just the person alone. So that's where the whole idea of the paper started. We had a bunch of volunteers, interns at Parliament India who helped us extract all this information from close to 1,000 medical records into Excel sheets, because Parliament did not have an online system which had this information. So all of this had to be extracted into Google Sheets for us to analyze it. And what we found was quite surprising, because when you think of India, Kerala is another country. I mean, Kerala doesn't fit into the regular India. And when we think of Kerala, we think, the people will be better off, people will be suffering less, economically they'll be doing better. But what we found was quite shocking in that regard. And Deepak, if you want to talk about some of the findings.
Yeah, so like Parth has already mentioned the intention behind the study, and I have been in the last since 2019, few years involved in providing palliative care at the grassroots levels in Karnataka, Tamil Nadu, and Kerala. More so, it was in Kerala because I was part of Pallium India, and they specialized in giving community-based palliative care services. And like Parth was mentioning, Kerala is seen as a state which is having high rates of literacy, standards of living, health literacy, etc. But then when I started visiting the field areas, and especially the rural areas, I understood that this is a far cry from the picture which goes out, and there are a lot of people, a lot of families who actually need quite a lot of support, and this is not the government's job alone. There is always people who fall through the cracks, and they need a lot of support, because it is not just one person or the patient whom we look at in palliative care. We are looking at the family as a whole, and that is exactly what the paper also started, sort of we tried to highlight in the paper, is that there are the illnesses of the other family members also take an impact, in a negative manner. Once there is a person having a life limiting illness in the family, the children in the family may get impacted. Their ability to earn an income and to sustain the family, to live with dignity, gets affected. So we were wondering, how is it that, what are the parameters we already have available, which sort of we can look at and analyze and see what comes out of it. And like Parth mentioned, it was not an easy job. All of these were in physical files, and we had to open each one of them, go to the right page, find out the required data. And even though there were forms which has the exact data, but some places it is written amongst the notes at some point during the consultations which had happened in the past. So this has to be mined out, and I'm grateful that a lot of people came together to do this.
So it was routine data, but it wasn't collected in a routine way for analysis. So there was still quite a lot of background that you needed to do. That's very impressive, because I will put a link to the paper in the show notes so that people can refer to it directly. But I mean, your sample size is great. You actually looked at 1,296, it says, sets of patient records, I presume, and almost 1,000 of those you could get data from. So it's a really excellent, yes, it's a snapshot, but it's a snapshot of a large group, and particularly in palliative care research. I think, it really stands out in that sense, the numbers that you're able to get. And there are a few highlights, I think. I don't know, you've talked about Kerala itself being understood in a certain way within India, which some people may be aware of who are listening, but others may have less understanding of that. But within that, even for you working in Kerala, you were still perhaps surprised by some of the results. Can you tell us about some of those results and maybe what surprised you about those as somebody who's from Kerala or working in that environment at least?
Right. So Kerala is known to have a strong public health infrastructure. That is, it has in India we follow a three-tier system. That is, there is primary healthcare, secondary healthcare, and tertiary healthcare. And the primary healthcare is known to be strong in India, which it is. But I realized that even that for that the medicines are not going to travel, or the support is not going to travel to a person's home. The person or some of the family members have to go to the clinic and actually procure these medicines or support system. And this is something which we saw was very much lacking, because many of these people, as the paper highlights, they are socially and economically disadvantaged people, and they are daily wage workers. Many of them, or many of the families, are daily wage workers. So if they miss one day of work, that means they miss that day's income. So it is a daily payment, sort of a daily income which they
Yeah.
have.
And
So
is there any kind of welfare system so that if they miss that day's work, that's literally it? They miss any income at all.
yes, yes.
They wouldn't
So
qualify for.
So if somebody is elderly, or if somebody is having cancer, these two groups have got so some welfare schemes in which they earn a monthly sum of 1,000 to 1,600 rupees, which is it's $10 to $15 a month, which you can imagine is not going to do much for a family of for even 3 to 4 people.
Yeah.
So this was one of the things which we saw. And even the medicines, even if though there are free medications, but there have been any number of months where the stock ran out in the primary health center, and they would just ask the person to come later.
But the paper itself, in a way, is not able to get into some of those real details that you on the ground know. But just looking at,
Yeah.
say, the paper reports debt, and the level of debt was over a third of the families.
Yes.
Obviously, and also I think the paper talks about, you talk about the fact that debt was the primary reason for debt with health related expenses. Do you have any idea if that level of debt is normal in India, or if this is different, or is this what you would expect? Because it's a high level of debt, isn't it? That you were talking about, sort of, particularly looking at those levels that you were talking about, the grants or welfare. I think you say something about a median debt of over $2,000, isn't it? So
Yeah.
it's a significant debt that people are facing.
Yes.
Parth,
Yeah.
do you want to comment on the debt at all?
So if we look at the statistics in India, every year around 55 million people fall below poverty line
Okay.
because of healthcare expenditure,
Okay.
because of catastrophic healthcare expenditure. So
From
we
any
normally
cause, for any reason, that's just
any reason.
Yeah.
Yeah.
Okay.
So we say that a majority of Indians are just one hospital bill away from poverty. And which is something which is, we did another study in Delhi, and that reflected the same thing, that a lot of families had debt, because what happens is, specifically when you have a life limiting illness, you are not really entertained in a government hospital, mainly because the government hospital is so overcrowded. their resources are prioritized. Younger people, or people who have curable diseases, they are prioritized. Somebody going with an old age, life-limiting illness will not be given priority there, which is why people often go to private centers, which becomes then the reason for death. So
Okay.
and what happens in private is also there is a level of exploitation where if you are sick and you are old, you will be directly sent to the ICU, and then you are charged bills, high amount of bills on a daily basis. So
Okay.
there are a lot of these ethical and sort of health system level challenges,
Yeah.
which made these findings not only surprising that one third
Yes.
of the families are in debt. This is actually way better than what we found in North India. So Kerala is still doing better. Uh, but if it's so bad in Kerala, you can only imagine how things are in other parts of the country where development is not as good as in Kerala.
Yes, yes. And again, your paper talks about the number of, I mean, thankfully, the number of people who, had limited, so they couldn't even afford food was, just under 10%. But those who couldn't afford medicines, and I presume these are kind of just, they're not curative medicines at this stage for Pallium, but, there'd be sort of comfort medicines or medication for pain or for, I don't know, hypertension or whatever ongoing medications people need. So people are not affording that kind of medicine. What are you able to do in that situation? Does Pallium have the opportunity to do to kind of fill in the gaps there, or is it just too much to fill in
Yeah,
those medicines and food?
so Pallium in that sense is one of the premier organizations in the country, which started over 20 years ago. And thanks to the founder, Dr. M.R. Rajagopal, who is a well-known figure in the palliative care space across the world, his integrity over a period of decades, starting in the early 90s, ensured that people contribute towards the cause. And all of Pallium's services were initially supported only by micro donations from thousands of people, contributing small amounts for years together. And fairly recently, I would say around 5 to 6 years ago, they started venturing into corporate social responsibility funds. India is one of the countries where it is mandated by law that any for-profit organization should spend 2% of their profits towards social causes. So Pallium has a team which looks into resources, to landing such resources, and through that we are able to procure medicines, and with the help of volunteers, we are able to deliver these medicines to the needy. So any instance we see that there are gaps, or there is possible gaps where a person may not get the required medicines, beforehand itself we start bringing them into our care, and supplying the medicines which is required on a monthly basis.
And obviously, this data that's being presented in this paper, it indicates also that Pallium is routinely gathering data about people's socioeconomic status, which I think may not be the case for some of us working in palliative care. I know in my work in Malawi, we didn't routinely collect information about people's household finance. I mean, it was a topic of a separate research project. And Parth, I think you've done some other extensive community-based work in other communities. Actually charting people's socioeconomic status. But I think it's very impressive and of note that within the framework of everything that Pallium does, and as you say, it is kind of world renowned, but also you have got this really fascinating data set. And I think we can also learn from that how important it is to gather data on this kind of information, not only for your own service, but also for the wider audience to understand the kind of situation that people with palliative care needs are living in. Parth, do you want to comment at all about your other work in Delhi that you mentioned? I know
Yeah.
it's
So
maybe about to be published, but I think it's
yeah.
irrelevant for this area.
Uh,
Yeah.
yeah, actually I got inspired by this Pallium's data set, and because while working with that data set, we also realized there were a lot of limitations. and somehow wanted to address those limitations in a study which we wanted to do prospectively. What we did was is also the problem is that in India we don't know how many people require palliative care in the community. Now we have those WHO estimates and serious health related suffering estimates 7 to 10 million roughly, but the density is different when we talk about urban slums. It's different when we talk about rural areas. And the issue is that then the policy has to be holistic so that it includes all these people, so that the urban poor are not left out, and it should not be only a rural centric policy. So what we did was in Delhi, we went around an urban slum, an urban resettlement colony, screened a population of around 45,000 people, and we found that out of 45,000, 90 people required home-based care, and not just palliative care, home-based care. So, you can estimate that the need for palliative care is much higher. It's just that these 90 people are stuck at home. So 2 per 1,000, which is a huge number. And out of every 1,000 people, 2 people requiring home-based care, which means they're either bed-bound or homebound. And what we found was, again, quite surprising that, again, 1/3 of them had debt, much higher than what was there in Kerala. And again, there were some families that were not able to afford even one meal per day, which is quite shocking. And also because the social security schemes in Delhi are not as good as they are in Kerala. So the findings were quite similar, but we had a more in-depth analysis here to inform, because Delhi is a smaller place compared to Kerala. And it gets a lot of political attention. So we thought, if we present a much detailed analysis, we hope that there will be a policy. But unfortunately, we're still working on it. Kerala has a state level policy. Delhi doesn't. So our aim is to use the Kerala model, show them that this can be done, and then bring something like that to Delhi.
Yeah, great. We probably need to be kind of winding up a little bit, but I suppose if I'd like to invite both of you to kind of suggest if there was one, I mean, not one actual person, but one type of person that you would love to read this paper and obviously take action on the basis of it. Do you want to say who that is and what you would want them to do? So, what are your hopes for this data or this kind of data in whether the policy space or the health system space or whatever? Would you like to just comment on that?
Yeah, I would choose the bureaucrats, the chief secretaries of health at state level, because in India the policies for health are made at state level for healthcare delivery. So I would just, if I would get some time off the bureaucrats managing healthcare, I would go to them, pitch this to them.
Right.
Yeah.
So the data is there. I guess there's a kind of another little challenge, another step always, isn't there? How do we reach these people, and what spaces can we occupy to make sure that they kind of hear this data, that is robust and is, gradually more and more comprehensive, and hopefully will have the intended impact of raising awareness and creating relevant policy and having that policy implemented so people receive the care they need. Deepak, do you have any thoughts on that? Who you'd like to read?
Yeah, I think people representatives who actually allocate the budget which is required for these kind of services. At the end of the day, it all boils down to that. I mean, we have seen the trends across the world that once the budget starts, is being made available, it starts trickling out from the coffers. That's when well-meaning individuals are able to do something about it. In India, there is no dearth of people, and there is no dearth of good willing people who want to do good for others who are in need. And it's not an easy task to do with the numbers which we have, the percentages which we are looking at. So a public private partnership mode has to happen for this, and definitely the government has to loosen its purses for to making this happen.
Yeah,
And I also
mean,
feel other organizations like Palliative, because again, this is the first study in India which has shown this, and now we have 28 states, 8 union territories, all
Yes.
400 plus languages, different cultures. Now, if every organization puts out data like this, it'll help us also in advocating from different regions, because everybody says, "Oh, Kerala is different." Why are you talking about Kerala all the time? But we need such papers coming out from other states.
Yes.
So yeah,
Absolutely, yes.
And it gives an idea, I think, of the type of data and how effective it can be. Because as you say, it was a lot of work, got a lot of manpower, came together, extracting the data, organizing it all. I appreciate that's a lot of work, but actually the fact that the information was there in the first place is really important for some people in other countries, maybe in other regions. Maybe they don't yet gather this data. But I think for all of us in palliative care, if we can begin to see the power of some of this data to impact those different stakeholders, those who hold the purse strings, the policymakers, it is really important, isn't it, to speak this language or whichever language they want to speak. I think case studies are always very powerful, but also for some, they need more than that, don't they? They need some of these numbers to help kind of think, okay, this is a significant problem. Maybe we need to do something about it in our setting. So I think the paper is also gives something which isn't too overwhelming. This was, I presume, not done with a huge budget or with massive research
zero,
infrastructure.
This was done
$0.
zero. Yeah.
You still manage to get it out, and I think that's also a real encouragement, I think, to others to say, yeah, you can do this kind of stuff. I don't know. Do you want to comment on anything else relating to the paper or the process of putting together, or before we come to a close?
No, I would just like to offer support if anybody wants to do similar work. I'd be happy to provide any technical support to replicate this work in any of the regions of the world. If anybody wants to do it locally, happy to help and improve palliative care, especially in global south. But yeah, happy to support even global north organizations which are working with marginalized communities.
Fantastic. Thank you, Pal. Deepak, anything you want
And
to?
from my end, I'm sure that there are many organizations, there are many individuals who are trying to do something, but maybe they don't know how to go about it, facing a lot of challenges at the ground level. And this is one thing which I keenly look at, that what are the solutions which is locally available, affordable, and it can be easily accessed. So any strategies, brainstorming, troubleshooting, which passionate people would like to do, I'm definitely on for supporting them.
Sure. And I think that also raises the point that I think there is so much going on in different countries in the global south, or as you say, Path, with marginalized communities and sharing ideas. Obviously research publications is one way of doing that, but creating forums in which people can discuss together from a very practical point of view, so that the research doesn't just stay on a page, but it actually makes a difference to patients and families, which at the end of the day is the important thing. But I just want to thank you both very much today for making time in your evening after work, I'm sure, busy days, for talking with us and talking about this paper. And I won't be surprised if I'm back in touch with you to speak about other things in future. But thank you very much for joining me today. Palliative care matters, because palliative care isn't just a specialty. It's something we all do. Subscribe wherever you get your podcasts.